list this week, so I'm just going to be a passive observer.
All right, I've got just two, but two good ones. Travis, do you have any cases?
Yeah, I've got a few I can show.
All right, you want to go first?
You go ahead, Jeff. I'm still prepping things.
Oh, sure. All right. So I will share these two. Let's see. So this first case is a young person. He's about 20, I think, at initial presentation. Let me get the right one here. So he presented with a lot of swelling and pain in his flank and lower pelvis. And you can see on this abdominal CT, there's this abscess-like collection down in the left lower pelvis. You see in the paraspinal muscles, there's multiple abscesses here, and it gets quite big. And then there's some osteolysis as well of the pelvic bones, and then it extends internally as well. So this large collection here. He also had a chest CT at the time that shows there's a lot of motion artifact, but you should be able to make out a background of multiple tiny nodules. So he has this biliary pattern. So they sampled some of the fluid in the pelvis, and this was all Mycobacterium tuberculosis, and it was all pan-sensitive. So he was started on therapy, underwent a bunch of drains of those abscesses. I have no intermediate imaging, but this was his most recent imaging after completing therapy. And you can see that the abscesses have been drained. There's still some bone erosion, but you can on the bone, sorry, the bone windows, you'll see that there's sclerosis. It's healing. And these are about a year apart, a little bit more than a year. So therapy. So that's that. And then the lungs also cleared up quite nicely. So he had no underlying risk factors for disseminated disease. He wasn't immune suppressed, but he was from an endemic area, and that's his only risk factor. So usually we see this more in our transplant patients or patients who have HIV or something like that, but no, he didn't. He was a young, otherwise healthy person, but unless he has some undefined one, but must have just been unfortunate, bad luck that got disseminated disease. But this is one of the cases, I've not seen this much sort of soft tissue involvement with TB before, so I thought it was a nice case. And the lung nut findings would be very helpful in making that diagnosis. Blastomycosis could also do that, but it tends not to form so many abscess pockets, but rather more inflammatory pockets and osteomyelitis. And it can also give you miliary disease. And then this other case is a woman in her, I believe she was in her 60s. She had kidney transplant for chronic kidney disease, and it was complicated by sort of delayed graft function and some wound healing issues. But other than that, was doing okay, and then developed a cough and a fever. And you can see on this chest radiograph, there's dense consolidation in the left upper lobe. There's less dense consolidation going further down that lung. And on the lateral, you can see it's primarily in the upper lobe, but there's this sort of this mass-like component to it. So they did a CT scan that really shows the same thing, but we can see in this area of consolidation, there's some small areas of cavitation. There's some satellite nodules, some surrounding ground glass opacity, and some expansion pushing on the fissure, which we saw on the radiograph, and just a little bit of involvement in that left lower lobe. So they cultured sputum and everything. All the smears were negative. AFB was negative, but then on culture, this grew out nocardia abscessus, which is one of the species of nocardia. I think that used to get thrown in the Asteroides complex, but it's one of the more common species of nocardia. And she had a brain MRI as part of her workup, showed no CNS involvement. So she was treated with 2 drugs for a year and cleared all of her disease. I didn't save the follow-up imaging. It just shows a little bit of scar. But nocardia is opportunistic in most cases, and it often looks like a fungus on CT. even though it's a bacterium. So it tends to cause large masses, cavities. You'll notice there's not really much in the way of pleural involvement. There's a tiny effusion, which is probably more reactive. And she did have a little bit of lymph node enlargement, but nothing terribly exciting that you typically would see with, say, pneumococcal infection or staph. So normally when I see this, I think about blastomycosis, but also, and especially an immune compromised patient, consider nocardia as well. All right, well, those are the two cases I have from this week. And I'll turn it over to Travis.
All right. I've got a few. I'm not sure how long we can keep this going, but this first one, I'm not sure, Jeff or David, if you guys are using any vessel suppression software for nodule detection or whatnot, but I think this is a good example. I don't make any money from River Rain for the nodule suppression software, but I think this is actually a useful case for it. This is a patient that studied really nothing, but I think this highlights some of the benefits. I think sometimes our residents like to find every little 1 and 2 millimeter nodule they can, which I don't think is necessarily the best use of the software. But there's a nodule hiding on this image that on a prior study from a few months ago was not present, or was like a couple millimeters smaller. And I'll let people look and see if they see it. It's certainly, we know blind spots are centrally and along vessels, but I'll show you, if you're looking at the vessel suppression. If you haven't seen this before, so it's a product that, will subtract out the airways and vessels, and sometimes it leaves you artifacts. So you see, a lot of times stuff that's central is actually still vessel that doesn't get subtracted. But sure enough, right here you can see that nodule, really shows up and was not seen on this study. I think this is just a classic incidental nodule case and kind of a Swiss cheese model, because here is a couple months later they get a thoracic spine CT, and definitely getting bigger there, and then was eventually picked up on a follow-up study when it was a larger lung cancer. But do you use anything like this?
Yeah,
anyone?
We use the same product, and it comes as part of their CAD. Yeah, and I'm not the CAD has its own limitations, but I love the vessel suppression. I put them side by. I actually have a viewport set up so that I have them loaded in parallel, so I can just scroll through them. It's sort of my second survey. We have found several cases like yours where there's a subtle cancer or metastasis that's hiding near central vessels or something like that.
Yeah, and I know, talking to a friend at Michigan, I think they have the full CAD system. We don't have a CAD, we just have this. But
that's all you need.
These are the types of things. Yeah, exactly. But you'll see a couple little 1 to 2 millimeter things that pop up, which obviously we should in most cases just ignore, but because it's just essentially noise. But this is the type of thing you're looking for. I thought this was a good example of the benefits of this.
Yeah, that's a great case.
All right. This one, I think, is just a nice radiograph. And it's one of the nicer lateral views, I think, because you don't see the air fluid level, maybe a little bit here, but I think hopefully everybody recognizes that the retrotracheal space or Rader's triangle is opacified here. And not only that, the trachea is being displaced substantially anteriorly here. The trachea should be probably up more in here. And when you see that, you think something going on with the esophagus perhaps, or an aberrant vessel from the aorta. You can see a corresponding finding on the PA view. And then of course it extends down into the azigoesophageal recess. And you can see, on the retrocardiac clear space on the lateral view also is, something here in addition to the aorta, which is more posterior. So this was actually an older patient that was, did not have a diagnosis of achalasia, but you can see the amount of mass effect on the trachea here on the CT, and I'll zoom in on that. But considerable mass effect, and they did scope the patient just to ensure there was no obstructing lesion down here, and there was some just chronic reflux esophagitis, but this was, I think this woman was in her 60s and was diagnosed with that. So kind of a unusual late presentation, and I don't know how long her symptoms were actually going on, but pretty dramatic example.
Yeah.
All right, let's see if I can get this one in order. So this is a patient that started out, and this is their pre-TAVR CT. And the most notable finding was that they had an abdominal aortic aneurysm here. And this, if you saw the title, this is what comes into play later on with this case. There's a little bit of slow flow, and I think there's heterogeneous opacification of the abdominal aorta there. And they underwent a TAVR and then had abdominal pain. And so you can see that at this point, they only did an abdomen and pelvis, but this dissection was new from the pre-CT. This is a couple months, I think, or less, or just over a month. So this was almost assuredly an iatrogenic dissection of the abdominal aorta from the catheter intervention for the TAVR. So then, this was the next day. Then they followed it up with a CT to follow the chest to see how far up into the chest the dissection was going. And you can see there is a fenestration there, and it's a type B dissection. You can see the transcatheter aortic valve replacement. But this was the next day, and one of the person reading the study noticed just at the inferior most image that there was a little bit of new stranding at the root of the mesentery surrounding the aorta. And it turned out the patient was having some issues with tachycardia and whatnot at that point in time. And so the question was raised, well, was this just a dissection now, or was that combined with the aneurysm complicating this even further? And sure enough, this patient over the course of that day had started to rupture their abdominal aorta. So it's really just like, a series of events, one following the other. And then they eventually got a stent of their descending thoracic aorta for the dissection, and had a stent in their abdominal aorta as well for the rupturing abdominal aortic aneurysm / dissection. So I don't think I've actually seen an abdominal aortic dissection before, lead to rupture like this in the setting of a AAA. Usually AAA is just rupture. But even on this, this CT right here, this was, there was no real sign that aorta was impending, that rupture was impending, even though it is pretty large at that point in time. So just kind of an interesting case that could be an entire lecture in itself on vascular processes, because it was over 7 centimeters there.
Nice.
But really good pickup here, just looking at the inferior most image and seeing just subtle stranding that they thought could be blood, which turned out it was blood.
Yeah, that's a particularly noisy image too. Travis, I think we lost your audio, or at least I've lost your audio.
Oh, I lost you there for a second, Jeff.
Oh, I lost you too. Okay. I was saying, yeah, that was a nice case. And
can you hear me now?
Okay. So I can hear you now.
Okay, I'm here now. So this is a crazy case, and David and Jeff, I want your thoughts on this. So one of my colleagues saw this and made a very good observation. So the history here was trauma, and this was the trauma, just portable radiograph, and noticed that the diaphragm looked a little peculiar here, but didn't stop there and noticed, this is a younger patient, that you have this curvilinear vessel right here, and notice that the right lung is certainly smaller than the left, and put this all together correctly, as it will turn out, that this was, of course, a scimitar vein and congenital venolobar syndrome with a hypogenetic right lung. But they went digging and found that she had had a prior renal stone protocol CT, and let's see, when was this? Was 14 years prior. And you can see on the scalp clearly the scimitar vein here, but notice the diaphragm doesn't look as abnormal. So the question was whether or not there was some traumatic diaphragmatic injury as well, since this was a trauma. And looking back at that old CT, unfortunately, they did a very good job of collimating off the lung bases. But it turns out it looks like this is the right side, but back there, she already had some sort of diaphragmatic defect. And my question then for you guys, and I don't know, because we do have a CT, and I'll show it to you right here. I know we've seen a case, and I think David or Jeff, one of you mentioned like the idea of the double diaphragm or duplicated diaphragm in the setting of scimitar. So here's the scimitar vein. And this is not just an acute traumatic diaphragmatic hernia, but I don't know if there is diaphragm above this, or if this is some sort of, or if I don't remember if our other cases, if we've seen, if this is just happens to be a huge Bachdelic type hernia associated with the scimitar, or what?
Yeah, I mean, I think David shared a case that had an extra slip of diaphragm, and if I remember, that one was associated with the quote horseshoe lung, which really isn't. But that's a tough one. I don't know, but diaphragmatic abnormalities are well described with scimitar.
Corona would be
typical Bachdelic, though.
Yeah, can you show us a?
Yeah, I wish I had thinner slices, but this got done elsewhere. There's definitely, and I think it is too lateral to be just the Bachdelic. It looks, yeah.
Right. So I think if there's a nice smooth covering over the top, then maybe it's a weird eventration, although it's pretty far lateral.
Mm-hmm.
Bob, could you lighten the window here, get us less contrast, lighter? But I think it's kind of. Yeah. I think it's probably a weird hernia, and it looks as if it's larger on that 14-year previous thing. So the question is this a traumatic hernia that's acute, or is it an enlargement, a slow enlargement of a pre-existing hernia?
And that was our question too. And at first we were thinking it was probably traumatic, but then we found this old CT, and she's prone here. So I mean, her kidney's way up by her liver, even 14 years ago. So I got the best guess would be that this is some sort of congenital hernia that may have been associated with the scimitar. And I think you can see there's diaphragm slip here, and also it's like, does the prone position for some reason cause it to reduce more than when she's supine? But yeah, but I mean, yeah, so we ended up thinking this was not a traumatic hernia, at least not an acute traumatic hernia. So
was she having, if she wasn't having pain in that location, then that would support your notion that this was
right. Right, and I don't know, since a lot of this, after the radiographs, the CT got done outside, so I don't know what exactly happened, in terms of if they're going to repair this. I mean, hopefully they're going to repair her scimitar. But going back to that, I guess we didn't even really talk about it. But yeah, the typical findings that we've discussed, it's been a while, I think, since we've shown a lot of scimitar cases, but you've got a rudimentary right lung here with kind of a right upper lobe bronchus, and then not really a bronchus intermedius, and just a few basilar segments, or maybe you argue this is right middle lobe and right lower lobe, and there's no right upper lobe, but definitely abnormal airway anatomy and no real fissure here.
No, and I didn't see only atrial. One pulmonary vein on the right there.
Yep.
Nice.
So yeah, so there's still one pulmonary vein that drains normally into the left atrium. I don't see a big atrial septal defect, and it certainly doesn't look like she had a shunt vascularity. But yeah, so just it was a really good observation on the radiograph.
Yeah,
I think it'd be
no
easy
kidding.
to just say, oh, traumatic hernia, next case. But it was, yeah. All right, speaking of which, and I think after this one, I can pull up one more case.
Yeah, and I found one more I can show too.
Okay, so we can go back and forth, yeah. And I don't think I've shown this one. We have several traumatic aortic injuries here, but this one in particular, I think, is a good example because I think everybody jumps on the fact that there's a layering left pleural effusion here, and probably a deep sulcus sign. We don't really get down there, but it's, you got some lucency here. So it's probably a layering hydropneumothorax. And I think the fact you can kind of see the left heart border a little sharper than you would expect. But often we just attribute the pleural fluid medially here along the mediastinum rather than mediastinal widening. But of course, in this case, we have other findings, the trachea being shifted way to the right and the left main stem bronchus being depressed. We've kind of lost the aortopulmonary window in the left PA here, but in good technique here, not a lot of rotation. So you'll see that this was quite the aortic injury. They did put a pigtail catheter in, even though this was all hemothorax. I'm not sure exactly what that was, but this was a little bit lower, just below the isthmus here, but just huge hematoma. And then, traumatic aortic injury, whether it's transected or whatever you want to call it, but many findings of direct aortic injury or direct findings of aortic injury there. And this guy did survive though. So he had a stent, and that hematoma eventually decreased. So
that's impressive. That's a big hematoma.
Yeah. Yeah, and so a lot of this stuff medially was also just apical cap along the subclavian artery, and some of it was blood too, but a lot of this is in the mediastinum and along that left subclavian.
Okay.
Well, and then also dissecting into the extrapleural space, so it's really an extrapleural hematoma over the apex.
Yeah.
And that's the same space that pneumomediastinum goes into and gives you pseudopneumothorax.
Right.
So
yeah,
the
that's a good point.
You just peel off, if you have something behind the mediastinal pleura, that becomes continuous with the parietal pleura that goes over the apex. And
so between the parietal pleura and the endothoracic fascia, I would think, yes, at least along this portion, yeah.
Yeah.
So, all right, Jeff, I can pull up one more if you want to go.
Yeah, I'll show this one. So this is a youngish person who I don't remember the history exactly, but had a chest radiograph for a reason, and they saw a mass, so they did a CT scan. This was done elsewhere, and you can see he's got this very funny calcified mass arising in the region of the aorta. They did a I don't know why they did a pre and post contrast, but they did, and you can see this does enhance, and this is just part of the ascending aorta here. So we have an ascending aortic aneurysm with this very dense calcification. Now notice he has no atherosclerosis anywhere else. He does have some effusions. Here's the sagittal showing that fusiform dense calcification. So I don't have a definitive answer, but it would not surprise me if this is related to syphilis. There's no history of aortitis otherwise, no connective tissue disease. And I know David has shown some cases like this before, and I remember learning this from him. It often gets this really thick, sometimes bark-like calcification from syphilis causing an aortitis in the ascending aorta, because most of the time, most people, even with bad atherosclerosis, have less involved in ascending aortic involvement, or if they have it, it's diffuse. And given the lack of atherosclerosis anywhere else, and I want to say this guy was like 30, I suspect this probably is syphilis. I don't know if you have any other ideas or comments, but that would be my leading diagnosis.
The other thing I'd like to do is to continue out into the right brachiocephalic artery. So
take a look at that
and see if that if it involves that, because that's
it's trying process. It's getting right there to the origin. Yeah, and if you look at it, it's on a different window. You can see it's almost like
Wow.
a milk of calcium there.
Yeah, I like your.
How old was this patient?
He was like 30 or something. He was young. I mean, he's male, so Takayasu's really isn't on the differential. And usually patients with that have a history of it, or they have other symptoms. This was incidentally picked up on a chest radiograph because they did a belly. I think they did a belly CT for belly pain. He had effusions, and so that's what prompted the chest CT was the abnormal radiograph. But given that, I mean, if you look at the rest of the vasculature, it's perfectly normal. I mean, there's nothing. There's not even a fleck of calcium. I can't imagine this is. He was too young for giant cell. As far as I know, he doesn't have Ehlers-Danlos, and they don't usually get calcifications. They more just get aneurysms. So,
Wow.
it's syphilis, but it's just a nice example, and it's always in that differential. And I mean, we've even seen cases at UW in the past where it's not something we typically think about, but that turned out to be syphilis. That because the incidence of syphilis has increased in the U.S. over the past decade. So. All right.
All right, I'll share my last one. It won't let me share, Jeff. You'll have to invite me, I think.
Oh, that's right. Sorry about that. Try now.
All right. So hopefully the incidence of this is decreasing, and I think it is with improved techniques, although it's still seen. This is from a colleague who's in private practice, and he saw this and made the correct diagnosis. You can see this patient's already intubated. They have a dilated esophagus, and this is a patient that came in with fever, altered mental status, a lot of, he was acutely ill. And as you scroll down, we will notice that the major abnormality is that, which is quite a bit of air in the left ventricle. And with the dilated esophagus, I don't know why it's dilated all the way down. That actually is unrelated to what this is. I don't know if it contributed to this complication at all, but this is a patient that did in fact have an atrial ablation for AFib about 4 weeks prior. So atrioesophageal fistula, of course, is the most feared complication, unfortunately rare, but usually happens 2 to 4 weeks afterwards. And the presence of the air there, even if you can't see a direct communication, is virtually diagnostic. But in this case, you can see there's even this extra fleck of air right there, that kind of indenting into the left atrium. So it's hard to see what's actually esophagus and what's left atrium. But between the two of those, they came down hard that this was an atrioesophageal fistula. Now, I think and this happens in a lot of cases because I've seen many instances of this where it's so rare that I think surgeons are hesitant to believe, so they quickly did, or shortly thereafter did, a gated cardiac CT. You can see they've got a PA catheter in now, and here you can see that little focus of air, and there's also this little string extending into the lumen of the left atrium, and I know Howard and I have both shown cases similar to this, and so there's a little bit of thrombus or whatever from his esophagus extending into the left atrium there. So it's hard to see the actual tract. You shouldn't, because it's an intermittent fistula. Otherwise, they just get such a high volume of air that they don't survive. And at this time, there's still a little bit of air left in the left ventricle, but not as much left. So this patient did go to surgery. They found about a 2 centimeter hole in his esophagus, 1 centimeter in the atrium, and were able to patch it up. Now, by report, he also had air emboli in the brain, but has survived, which puts him in the minority of patients and hopefully will recover. But this is another atrioesophageal fistula. And so, with improved techniques, these are supposedly decreasing in incidence, but they're still important. And the surgeons always want to explain this as just because of the PFO or the atrial septal defect they create when they do the ablation. But I think everyone would agree that we've never seen air in the left side of the heart except in this situation. At least I haven't.
Except for
So.
contrast injection on CT. No, I'm sorry, that's on the right side.
What's that? Yeah.
I take it back.
And this patient actually had
left. Right.
Yeah, that patient had a little bit of error from the contrast right there. Presuming, well, and actually, David, we see it all the time on non-contrast CTs, so I don't even mention it anymore on CTs if it's in the pulmonary artery, because I think most of the time it's probably just from flushing of IVs.
Right, for sure.
So, yeah, we used to think it was all IV contrast injection, but when I see it on non-con patients that have never gotten contrast, and you realize it's from something else. But yeah. I don't think they had any error in the appendage. Yeah.
Cool.
All right, Jeff.
All right. Well, thanks for the cases. All right. Well, we will wrap it up early today, and have a good week.
All right, guys.
Take care.
Thanks, everyone.
See ya.
Bye.